I'm Jack Braha, your host of Medcastplus. On the show, we feature local healthcare providers and physicians to educate us on various medical conditions and provide us with some very helpful health tips. Today, we welcome Dr. Steven Pulitzer, Chief Medical Officer at New York Health and Hospitals Kings County Hospital, which is here in the heart of Brooklyn. Dr. Pulitzer will update us on how he is helping to bring state-of-the-art care to NYC H&H Kings County Hospital, something he refers to as Kings County 2.0, which I thought was a great title for today's show. And while we're not going to talk about a specific medical condition today, Dr. Pulitzer is going to talk about the advances and all the great things happening at Kings County Hospital here in the heart of Brooklyn. Dr. Pulitzer, welcome to the show.
Thank you very much.
Great to have you here to talk about one of our county's oldest institutions, greatest institutions, providing health care for the large, vast portion of this county, and sometimes some of the most difficult cases, unfortunate patients come to your hospital. So, welcome.
Yes, thank you. Thank you for having me on the show.
Thank you for being here for all the population of Brooklyn. And as I started off the show with Kings County 2.0.
Yes. So
what does that mean?
So Kings County 2.0 is the new way that we are able to provide health care to a population that has very few resources. A number of our patients have a lot of social determinants of health, which is a buzzword these days, and really have barriers to receiving great care and being able to continue with their care plans and care treatments due to some of these barriers. And
so some of these barriers, for the viewers today, what do we mean by social determinants? Right, it's a buzzword.
Right.
We see politicians talking about social determinants. We see the news talking about, but what it really means for us as doctors is something is blocking this patient. Something is causing something with this patient not to be able to get what we would consider the standard or the best health care available to them.
Correct. So there's patients who have food insecurity or housing insecurity or street homelessness, patients who have undocumented immigration status and are not able to get insurance. There's a lot of barriers that people will have in order to first make it to the hospital and second be able to receive the resources that we can give them and continue on in their own, if they have a home to live in their home.
Right. We talk about this a lot, and as you and I, when we were training and we were residents on the floor or the ward of the hospital, we'd be going down the hallway, and every now and then there would be a patient who came in for what you and I would have thought was not an emergency, or something that you didn't need to come to the ER for. For example, we used to admit patients who ran out of medicines.
Yes. But
we would admit people who ran out of food.
Yeah.
They didn't have a place to live, and while it wasn't something I was trained in medical school to fix, this is a huge medical problem,
yes,
healthcare issue in our county and across the country. Despite a booming economy and all the great things that we see with jobs and people getting work, there is still a population out there who needs Kings County.
Correct.
Needs a hospital somewhere, and admitting them is probably the easy part. We have an emergency room. You bring them on in. And you have a great emergency room at Kings County. I mean, you guys can handle anything, really, right?
Yes.
But it's a busy ER, I'm assuming, because of some folks that come in because of social determinants.
Correct. We have a lot of patients who are high utilizers of our ER systems.
Meaning they keep coming in.
They keep coming in repeatedly. And oftentimes, I think, if we're going to differentiate Kings County 1.0 from 2.0, we wouldn't really pick up on the fact that this is a high utilizer. We would move them through the system. Perhaps, as you're saying, they don't have medications. We'd admit them. We'd try and get them out in a couple of days, and just, it would be a cycle. They would be coming back.
It was a vicious cycle. I trained at Maimonides, not too far from you. It's the same situation. We knew the frequent flyers who would come to the ER. But that's a problem.
Right. And so, when you sit back and you ask somebody, well, why are you coming today? What is it that's really making you come here today? And they say, well, I ran out of food, or, it's cold out and I don't have a home, or I don't have a place to go, or, simply very, very basic things like that. And no one's really taken the time to sit and ask them, what is it that you need? And unless you are screening for something like the social determinants, you may not pick that up.
We're just pushing the paper.
Correct.
That's what we used to do a lot of is, patient came in and said, I have diabetes, and the sugar was a little bit high. The ER would admit the patient for uncontrolled diabetes, but the real situation for the patient was every time we gave them a prescription to go home now, we got the sugar great, normalized in the hospital, and we sent them out with paperwork, but they couldn't fill the prescription. So these issues, to me, are really important. I think it's very easy for me to stop GI bleeding. It's very easy for me to go take a polyp out of someone's colon. That's easy. Here it is, take it out, remove it, they go out the door. But what you're talking about with Kings County 2.0, the next step in preventing patients from suffering from these social determinants of care, whether they need a place to live, need a meal, help getting their medications, you can reduce the clutter in the ER, the clog, the backlog in the ER by discharging people safer, better.
Yes, absolutely. And to go with your example of a patient who's diabetic, we would do exactly that. We would have a patient come in, we would tune them up, we would send them out, and when they left, their sugar was perfect. They were eating well with us. Everything was fine. 2 weeks later, they're coming back. So we now have a screening tool that helps us to identify patients who may not want to make that, tell you right off the bat what's going on with them, and that they need a different kind of care. We have developed, and this also goes to the 2.0, our structure now is a multidisciplinary clinic where we have social workers, case managers, care managers, dietitians, we have a bariatrics team, and we have a kitchen, and we have an endocrinologist that all share in one space. So when we find somebody who is coming back to us a few times, their sugar is really not being controlled, they either have type 1 or type 2, we send them to our diabetes boot camp. And at the diabetes boot camp, it's a 90-day course. There's education. We have a kitchen. We teach them how to cook. And we have something that's very unique now is that we actually have a food pharmacy. So I can write a prescription for somebody and say, here, go down one level, and they can go shop in our pharmacy and get the healthy food that they need, and they can come back as often as they need.
Does this cost them anything?
No.
This is incredible, right?
Yes.
This is game changing. This is 2.0.
Yes.
So this is the transition from 1.0 to 2.0 is very difficult, but you've obviously been able to do it. Comprehensive care to now give the patient a hug and say, hey, listen, you're walking out the door with your sugars under control.
Right.
We're going to keep you at it.
Correct. And I think that the biggest paradigm shift is how you view public health. It used to be thought that our job was simply ending at correcting the sugar and sending them home, but really, like we're a large trauma center. And to give a different example, a young person comes in who's ambulatory, they're undocumented, they have a job delivering food. They get hit by a car, they break their leg, and they can no longer ride their bicycle, right? They live on the 3rd floor of a walk-up, and now they have a big rod in their foot, and they can't ambulate. So our job used to be, okay, we fixed your leg, and now you can go back home. But how does that person get upstairs? How do they get to the food that they need? How do they fill their prescriptions? Who is going to check up on them in 2 days or 3 days? This is where that paradigm shift is, because that's the help they really need. They need that first couple of weeks.
This is where the social worker team that you mentioned comes in, the interdisciplinary team. I think it's sort of one of the, I don't want to say undervalued or under-recognized, I don't know what the word is, but these are the most important people when it comes to continuing what the doctors do in the hospital. So, as physicians, radiologists, I'm a gastroenterologist, we're good at diagnosing, we're good at treating things, but what is that continuity of care after? How are we sure that patient's able to do what we recommended? And the social workers are so important. In the hospital, I don't even think we have enough of them. I don't think we could ever have enough of them because every patient could probably benefit from their own.
Yes.
And so you have that team available to the patients at Kings County that you're not just sending someone out with a brace who can't walk to try to get up to the 3rd floor walk-up apartment. There's some plan in place to help and support this patient. Even undocumented, even without the means to pay, without insurance, we can still provide that in this city.
Correct. And that's a great segue. We have what's called DSRIP partners, and they're partners.
Yeah, explain this DSRIP.
Yes, DSRIP.
DSRIP, we call it in medicine, in the healthcare community.
Right, and so it started a couple of years ago with an incentive to get health systems to work closely with their aftercare partners. So there's financial incentives if you can keep people from coming back into the hospital, keep people from having readmissions that they shouldn't be having. And it really made us think, well, how are we caring for our patients? What happens when they go home? Where are they going? So we have things like something for H&H is called at home. So if you need to be seen at your house and you need some antibiotics or you just need a checkup, we can send somebody directly to you. We will send the care to you and the care that you need. So,
yeah, the district program and these other types of programs that are going on across the country have really been what we lacked in healthcare before, which is taking care of patients beyond the doors of the hospital, beyond the doors of the office. That while there are many patients out there who are able to follow every instruction of the doctor, take their medicines, there are folks out there with challenges, and this could be language, it could be disabilities, ambulating or getting to the doctor. So this patient-centered home or taking care of the patient at home is a very big and newer development. It's not entirely new because I think doctors started making house calls 150 years ago. Or in Brooklyn, I hear stories from some of the doctors who have a little bit more gray hair than you and I both.
Yes.
Tell us how they used to make house calls, and now there is some, I guess it's government or some other incentive financially to help with this.
Correct. And what's very interesting is that there's a movement now for complex care of patients, and especially patients who become high utilizers in the system. And they've actually dialed the clock back. They've wanting to have one physician take care of that patient through all of their needs and visit them at home and see them if they come into the hospital. And so they're really finding that one-on-one care is really how these patients are able to follow up.
Yeah, I think a lot of us as medical students, or even before, that's how we envisioned the old, was it Marcus Welby, type of healthcare. That I envisioned myself. I was an EMT before I became a doctor, so I saw what went on in the home.
Yes.
So I think I had a unique ability that a lot of us don't get in our training as physicians.
Yes.
And whether that's intentional or unintentional consequence of how we train, seeing a patient's home can really change things for a doctor. I spent, when I was training locally in Brooklyn at Maimonides, I elected to spend 1 month riding with the ambulances at the end of my residency.
Wow.
And it is a lot different, as you mentioned, at home for the patient and in the hospital. In the hospital, it's well controlled.
Right.
So you have a program that allows folks to be treated at home sometimes when they need, get antibiotics at home, sometimes intravenous, I'm assuming they can get treated, to help keep them out of the hospital. Or more importantly, the ER, where we're always worried about the wait and troubles. Tell us about Kings County 2.0 from a technology standpoint. We were chatting before the show, state-of-the-art software.
So we firmly believe, and this is the senior leadership at Kings County, that everybody deserves the same level of care that you would have at the university hospital that has the latest and newest technology. A lot of the technology doesn't run itself. It's the protocols that you put into it. And the protocols really don't cost anything. So if you want to treat patients with the best standard of care and you adopt the protocols from really strong institutions, we are able to show that our outcomes are improving. By doing that, we've now introduced some new physical equipment to keep up with that. And so we have a surgical robot. Our new robotics program went live in January.
We had your urologist on the show, Dr. Weiner.
Yes, Dr. Weiner. He's been spearheading it, and he's done almost 40 cases since.
And so for the viewers, these are not self-driving robots. These are not self-driving cars. There's a surgeon operating the robot.
Correct.
So you have the robot that's being used by the surgeons.